Great, excellent. So let's move on to the second talk. Essentially what we're going to do here is talk about kidney pathologies that are non-RCCs. So not everything that you see in the kidney is going to end up being an oncocytoma or a renal cell carcinoma. There's a few other things. I was confident that Hirsch was going to do a great job as he did and keep you all awake. I wasn't so confident that I would manage it, so I'm going to do it slightly different. It's going to be case review, so you're going to have to look out for the right answers and hopefully shout them out as well. We'll cover some of the non-RCC malignancies, but we'll also talk about some other benign renal pathologies. So this is the first one. This person is a man who's 55 and has this CT, and I'll give you some options. I already said it's not renal cell carcinoma talk, so A is not the right answer. But it is a urothelial neoplasm, acute cortical necrosis, or lymphoma. What do you think?
It's probably lymphoma.
Excellent, fantastic. So not everything we see in the kidney is going to be an RCC. That's message number one. This is a lymphoma. Lymphoma can occur anywhere in the body. It can occur in the kidney, and it has multiple forms of manifesting itself in the kidney. The most common is a secondary renal lymphoma. Usually it's not a trick diagnosis because they already have widespread disease elsewhere. They manifest on imaging on 1 to 8% of patients, but actually autopsy studies suggest that the prevalence of renal involvement in lymphoma is much higher than we think. And it might be that we're just not looking for it all the time. Primary renal lymphoma can also occur where the disease is localized to the kidney without any other organ or nodal involvement, but it's quite rare. It represents less than 1% of extranodal lymphomas. In terms of what lymphoma can look like in the kidney, the most common pattern is going to be multiple renal masses. That's going to be followed by direct extension from a retroperitoneal mass or a conglomerate adenopathy mass. Then you can get a solitary renal mass, and these ones are difficult. These occasionally can get confused with a renal cortical neoplasm. You can get an isolated perinephric mass, which is like the one we saw in this case, or you could simply have nephromegaly. Both kidneys are enlarged and you actually don't see a mass, or you don't see nodes, or you don't see anything else. This could be quite difficult. So basically you can see that it's a potential mimicker of a lot of different things. Renal lymphoma can actually look like anything, but for the most part it will look different than the renal cortical neoplasms. Second one here. You have a T2 weighted image at the top and a fat suppressed T1 post-contrast at the bottom. Going back and making the connection with the previous talk. Would you call this a clear cell carcinoma, papillary carcinoma, oncocytoma, or a urothelial carcinoma? Two important points about this case. One is that when we go into this whole thinking mechanism of is this mass enhancing, what is the diffusion characteristics, because we're thinking already RCC, if I don't see something that's enhancing, then I'm going to call it a papillary tumor. That's sort of the right way to be thinking about this. But Hirsch actually talked about this in his session too. You have to make the differentiation before you even get to that as to how confident am I that this is a renal cortical neoplasm versus a more centrally located tumor, in which situation you already should be thinking about a urothelial carcinoma. You already explained why it's so important. That's what it is in this situation. Even they can be quite difficult on CT or on MR when you're just looking at one face. If you have a CT in the portal phase, it can be relatively easy to miss, but it will essentially look like a central lesion with infiltrative appearance. RCCs tend to be more well demarcated, but if it's already known about or you do an excretory phase for characterization, then it becomes easier because you can actually see the filling defect within the collecting system, especially if the tumors are big. They account for about 5% of urothelial cancers. 95% of them are in the bladder. Most of them are invasive at diagnosis. They have increased risk for metastasis and progression. So that's why it's important to recognize and suggest, because actually the likelihood of dying from this is much higher than for the majority of the RCCs. So you'd rather overcall something and make sure that it's taken into account in the differential rather than undercall. Also, as Hirsch mentioned, the treatment is going to be different. So they need to do a nephroureterectomy in upper tract urothelial neoplasms versus just a nephrectomy in the RCCs. Now, not everything that looks infiltrative in the kidney is going to be an upper tract urothelial carcinoma. As we already mentioned, lymphoma can look like anything. So when you have a central infiltrating mass, in addition to urothelial upper tract neoplasm, you have to think about lymphoma. You have to think about non-malignant conditions like a focal pyelonephritis infection. And you have to think about vasculopathy or medical disease or other things. The point is that here you should branch out your differential beyond renal cell carcinoma, and what you should think of always at the top, because it's the most dangerous to the patient, is upper tract urothelial neoplasm. Okay, so what's this one? CT through the kidney and through the lung. I have options, yes. Lymphoma can look like anything, I said, so is this one of them? Or are we getting into the syndromes? I think I heard it. All right, so we have cysts in the lungs, a little bit outside of my area of expertise, but I know that you can get cysts with Langerhans cell histiocytosis. So anyone aware of any kidney manifestation of Langerhans cell histiocytosis? I'm not, so that's not the answer. Von Hippel-Lindau, you get stuff in the kidneys, right? You get cysts in the kidneys, you get cysts in the pancreas, you get hemangioblastomas in the CNS, but nothing really in the lungs. So this is the big mouthful word of Lymphangioleiomyomatosis, LAM, right? So you get a combination, I think I have a little slide here. The key is to identify that this is a bulk fat containing renal mass. As Hirsch mentioned in the talk before, when you have bulk fat in a renal mass, it's going to be an angiomyolipoma. So this patient has an angiomyolipoma, is a middle-aged woman, has pulmonary cysts. This is lymphangioleiomyomatosis. It's a rare disorder caused by proliferation of neoplastic smooth muscle cells in the lungs, kidneys, and the lymphatics, and hence the manifestations in renal AMLs, thin-walled symmetric cysts, and lymphadenopathy in the chest that can result in pneumothorax and chylous pleural effusion. It occurs almost exclusively in middle-aged women, so like the patient we just saw. Now, not everyone with AML has to have LAM, and not everyone with LAM has to have AML. So you see angiomyolipomas in 60 to 80% of women with LAM, but only 30% of women with an angiomyolipoma have LAM. So that makes sense. They're not mutually exclusive. Okay, this is another lady. She's 38. She's on chemotherapy, and she's acutely unwell. What is the diagnosis here? Pyelonephritis, ATN, acute cortical necrosis, or lymphoma. Now, the key to not calling this lymphoma is to realize that the abnormality, I'll give it away here, but that the abnormality is actually occurring inside of the capsule, right? So this is symmetric bilateral hypoenhancement of the renal cortex, which is consistent with acute cortical necrosis. Had this same finding, a rind of tissue, be seen outside of the capsule, then you would certainly have to think about lymphoma. But acute cortical necrosis, by definition, is ischemic necrosis of the cortex, secondary to vascular spasm, microvascular injury, or intravascular coagulation. Most cases are related to complications from pregnancy. Can also occur in childhood, kids with heart disease or perinatal asphyxia, but actually anything that makes you acutely unwell can result in this. Sepsis, like this patient had, pancreatitis, shock, trauma. The key imaging finding is, as we saw here, decreased rind of enhancement throughout the renal cortex. And remember, these patients are also in acute renal failure. So you can see evidence of that in decreased contrast excretion. And also think that you're actually making it worse, the renal failure, because you just gave them contrast. So this is something that needs to be recognized immediately and communicated immediately to the referring team, because a lot of these patients get pushed farther into renal failure and require dialysis for the management of that to minimize contrast-induced renal damage. Okay? This is a man, he's 31, presenting with tiredness, shortness of breath, and palpitations. What do we think here? T1 weighted image at the top, T2 weighted image at the bottom. Do the kidneys look normal? They don't, right? They look extremely abnormal, but whatever is happening to them is happening to both of them, and it's happening diffusely, right? So we're going to call this paroxysmal nocturnal hemoglobinuria, bilateral pyelonephritis, papillary necrosis, or lymphoma. Excellent. So what we're seeing, the right answer is paroxysmal nocturnal hemoglobinuria. So what we're seeing here is not direct evidence of that, but what we're seeing is renal hemosiderosis. So there's iron deposition within the renal parenchyma, symmetrically, bilaterally. So any condition that results in renal hemosiderosis will give you this appearance. Out of the 4 listed here, PNH is the only one that does. So PNH is a triad of complement-induced hemolytic anemia, red urine, and thrombosis. Some think that it's triggered by acidosis that occurs during sleep, hence the term. Patients wake up in the middle of the night and have hematuria. It's an acquired intrinsic defect in the cell membrane that can occur as a primary disease on its own, or it occurs secondary to other diseases such as aplastic anemia or myelodysplasia. The key imaging findings are, in addition to what we saw here, the hemosiderosis, the fact that these patients are prone to develop thrombosis. Thrombosis anywhere in the body, hepatic vessels, cerebral, superficial skin, everywhere. So basically, the clinical relevance and the management evolves around that specifically. The patients need anticoagulation, sometimes for life, so there's issues and potential complications from that. Imaging is primarily used to localize the presence of thrombi given the clinical symptoms. And for a long time, the treatment of this has been purely supportive, just with anticoagulation, although there are some clinical trials testing some more novel targeting agents and monoclonal antibodies as potential therapies. Right, case number 6. This patient is having an MRCP for abdominal pain and has a history of a psychiatric mood disorder. What is the diagnosis now? Infection, lymphoma, drug-induced, or renal cell carcinoma? Fantastic. Which drug? Excellent. Very good. So this is the classic appearance of drug-induced or lithium-induced renal disease. Lithium, as you all know, is used in psychiatry for the treatment of bipolar mood disorders. The key imaging findings is what we saw here, microcystic changes throughout both kidneys. The cysts can be complex. If you see, do I have it here? No, the cysts, some of them can be bright on T1 before the contrast, so that means that they're hemorrhagic, so they can be complex. It doesn't really make a difference with regards to the diagnosis per se. The clinical relevance, once you see this, is that the nephrotoxicity from the lithium can be significant, right? So the cysts are not necessarily the problem, but the lithium can result in nephrogenic diabetes insipidus. This is actually a life-threatening condition to have, so the treatment with the lithium needs to be stopped. The other important thing is that you don't need to be on lithium for decades to get this, so you can get it with short-term treatment with lithium or long-term treatment with lithium. So don't let the fact that the patient has only been on lithium for a few months put you off the diagnosis, because they must have been on it for a longer time. Okay? Case number 7. This is a young man in his 20s, comes to the emergency room with acute abdominal pain. We get very excited about the fact that he has a horseshoe kidney, first of all, and the fact that he has a weird-looking kidney lesion. What may it be? Horseshoe kidney, before we get to the actual lesion, relatively common congenital anomaly, together with other congenital anomalies such as pelvic kidney or cross-fused ectopia. Patients with horseshoe kidneys are at higher risk of developing renal cell carcinomas, urothelial carcinomas, and kids' Wilms tumors. They happen most commonly in the isthmus, the little bridge that joins both sides of the horseshoe kidney. And this is thought to be related to teratogenic factors where there is abnormal migration of posterior nephrogenic cells that coalesce. Now, I was dreading that I was going to give the answer. So what do you think corresponds to what the renal lesion here is? And this is a one-off that no one should get because it's extremely rare, but essentially this patient had a renal carcinoid, extremely rare condition. Having said that, I have seen 3 this year, so there might be an epidemic of renal carcinoids, I don't know. And the funny thing is that they all look the same. They look exactly like this, a cystic lesion with very coarse popcorn-looking like calcification. Now, I don't want people to walk out of this room and every cyst with calcification you see suggests that because Hirsch said, I have to say histology, this may be a carcinoid, right? It's still quite rare. In the case reports, the mean age is 41, similar male to female ratio. Interestingly, a third of reported cases are associated with horseshoe. The clinical findings are pretty non-specific, abdominal pain. Usually they don't have carcinoid syndrome. Like I said, the CT findings, they basically look like this. The case reports and the ones that I've looked, they all look pretty similar. The size is variable. They've been reported very small, from 1 centimeter but up to 17 centimeters. And usually they're treated with surgery and have a relatively benign course with low risk for recurrence or metastatic disease. Now, that was not the answer in this case, though. He wasn't coming to the emergency room because of his renal carcinoid. Why was he in the emergency room for? Fantastic, you're all awake. That's what I was testing. So the patient was coming for acute appendicitis. The whole history with the kidney happened later on. Fortunately, this was seen on time and described. So I think that's it. Any questions or any comments before we move on?